Wonderful. Hello and happy Friday. Welcome to our first community practice of 2025. I hope everyone has had a good start to the year. And if you received our email reminder, you know that today we are holding an informal panel for AOT peers from CMHs to talk about their roles in supporting folks who are on an AOT order. So we all know that peers play an extremely important role in the AOT process and on the treatment team. So I'm really, really excited about today's panel so that we can hear more about that. We have Clarissa Winters here from LifeWays CMH to facilitate the panel discussion. But before I kick it over to Clarissa to introduce herself and introduce the other panelists here with us today, there's a couple of housekeeping items I'd like to make you all aware of. So as I plug every single month, we have Dr. Scott Smith available twice a month for these AOT Q&A drop-in sessions. Anyone can come to these sessions with any AOT related questions. It is a drop-in, so you don't have to come on time necessarily, but anytime within that hour span. This is such a great resource to share with families and loved ones as well if they have questions and they, need someone else to talk to about that. As AOT gets more attention across the state, there's going to be more questions that are going to rise and maybe case-specific questions where you want to go and talk them out with someone. And I think, that space that Scott provides in talking about AOTs it's a great resource. So if that's not something you feel like you necessarily need, just keep it in mind for maybe when folks you're working with on AOTs may express that, you can share that resource and we can all learn from each other in that way. So I'll go ahead and drop those dates and times in the chat. But yeah, if you have any questions that don't get addressed here today, please be sure to attend one of these Q&A sessions. They're open to just anyone and everyone that has a question about it. So the next item on our housekeeping list is that we have an ask that we'd like to pose to this group. Through our various AOT projects and working with so many of you across the state, we're noticing that there are major differences in the court processes from county to county, and we're looking to get a better idea of these differences. So we created what's called a court variance survey. It's a survey that we would like people, all across the state, folks in your position and in other parts of the system of care. We'd like for y'all to fill that out. My colleague Sophie is going to drop the link to the survey in the chat, and I will also include that link in my follow-up email. But we're asking that you complete this survey or, like I said, send it to other folks that you work with on AOTs. This would just be an amazing help for us because we're continuing to get a better understanding of the barriers that folks are experiencing. And as we're developing and trying to identify best practices, we really want to get a better understanding of how these court processes differ. So completing that would be such a big help. And if you also want to share it with, folks that within the system of care that you work with on AOTs, that would just be wonderful. So I'm going to go ahead and also, if you're not familiar with our AOT toolkit, we're constantly adding new things on there. Like I said, this recording is added to the AOT toolkit, and we're constantly adding resources for different folks from the system of care, like law enforcement, inpatient hospitals, CMH's court. We're constantly adding resources to that. And as we're updating those this website, we'd like to ask people to join, or not to join, but to visit the website and make sure that it's that it makes sense, that it's accessible to everyone, because we've added a lot of new features. So if I'm going to go ahead and drop the link to the toolkit in the chat, and if you wouldn't mind just visiting it and looking through all the resources that we have, and if you have any feedback on it, like if something, the way something's laid out doesn't make sense, or what have you, or it's like, oh, hey, you're doing a great job, then we would love that kind of feedback so that we could make it as user-friendly as possible, because we're creating it for, you all, and and other folks of the system of care. So I'm going to go ahead and do that, drop that in the chat. But so those are the end of my housekeeping tasks. So without further ado, I'm going to go ahead and kick it over to Clarissa Winters to introduce herself and get started with this panel.
Thank you, Olivia. So hi, I'm Clarissa. Been in the community of practice ever since I joined the position as an AOT monitor back at the end of June. Actually, that was exactly 7 months ago. So I am also a certified peer support specialist. I'm from LifeWays, the CMH in Jackson. So I started at LifeWays almost 4 years ago. I would like a little over 3.5 years ago. And I started my position there as a peer support. So that's something that's very dear to my heart. I was inspired to join the team based on my own recovery journey. And I had gotten my degree, and so I moved into this position of AOT monitor because I really wanted to bring a sense of that peer work, that compassion in peer work to this AOT world, because it can be such a difficult, touchy area for the people that we serve. So yeah, and then now I'd like to introduce our panelists who can introduce themselves as well and tell a little bit about themselves. Trina from CEI, Trisha from CEI, and Jason from Genesee, who I believe is running a little bit late. I think when he jumps on, um, we'll introduce him as well. So if Trina and Trisha, if you're on, if you want to introduce yourselves and tell a little bit about yourselves, and then we can go into the questions.
Hi, thank you so much, Clarissa, and Olivia. So my name is Trina Poland. I am a certified peer recovery coach. I've worked in this field for about 5 years. I have switched some programs, moved around a little bit here at CEI, and I'm currently the lead peer here at CMH. So my role is, a lot of it is to support the peers that are supporting our consumers. And so yeah, I'm very passionate about what I do. I heard you say the word compassion, and I think that's one of the most important aspects of my role when I'm working with consumers that need support. So yeah, I'm just happy to be here, and I hope that was enough information. Thank you.
Hi, I'm Trisha Schindler. I am the peer support for the court team at CEI CMH here in Lansing. I have been a peer support since 2019, I believe. I came from Lenawee County and moved up here with Christie's new court team, and have absolutely loved building this team and watching it grow exponentially quickly.
Awesome, thank you. And I think Jason just joined. So Jason, I was introducing the panelists, and I think you were next if you want to introduce yourself and say a little bit about yourself.
Hello, can you hear me?
Yeah, we can hear you.
All right, hello, my name is Jason Scales. I work for GHS, and I've been to peer support. It will be 2 years next month. I'm a music business Bachelor of Science, and I'm also a facilitator of 3 groups. I facilitate the mental health group. I also do the RAP group, which is Wellness Recovery Action Plan, and I also facilitate the domestic violence group.
Okay, great. Thank you. So yeah, we went through and introduced the other peers, Trina and Trisha, and then I introduced myself as a peer. So it's good to have you here. And I guess without further ado, I will go into the questions that we have for the panel. So I guess feel free to just jump in when you have an answer. So the first question is, what different needs to AOT consumers what different needs do they have compared to others who need peer support?
You want us to raise our hand or just answer?
Um,
How would you like us to?
yeah, I guess
I-
raising is good.
Sorry, I guess I'll start. One of the biggest differences that I see is that sometimes folks on those AOT orders need a little bit more support and understanding of their mental health treatment and accepting that they need mental health treatment a little bit more than the community that's coming in for help on their own.
You, Tricia, and I think Trina, you had an answer as well.
Yeah, I think just to add to that, I was thinking like more education around medications and the actual order, understanding that it's not a criminal matter, and just kind of extra support in their recovery journey. So yeah, just to add on to what Tricia said.
Yeah, thank you. You know, I found that too in my work as a peer, especially with the AOT clients, some more attention I needed for like to engage them in their treatment. So that definitely speaks to what you talked about. Okay. The next question is, what do you wish people knew about your role and position? Head, Jason.
Okay, yeah, so it definitely, for me, the most part, it keeps me mindful that I can always be the one who's on the other side of the table. So I think it gives me a sense of gratitude and being grounded.
I would like to add to that, what you just said, Jason. I love that. And also, the value of lived experience. I think as a peer recovery coach, I think that is starting to be valued more and embedded kind of in all of these teams and these agencies, but just the value that that brings to the table.
I agree with both of them as well. And also, um, our role is sometimes confused as more of a police officer, probation officer, or something like that. And it's not seen as we're trying to help. So trying to get the clients and consumers to understand we're here to help you engage and help get the help you need. This is not, again, a criminal matter. This is something to help you, not to go against you.
Right. Right. And I think that the lived experience and being a peer can help build more of that trust or like that connection with the clients. And so hopefully, when they're on AOT, they can, have that, again, that sense of trust and connection. So yeah, thank you. Next question is, how does your role support people with a substance use disorder?
I think the AOTs sometimes make it harder to help folks with substance disorder just because we can only mandate that mental health use or the mental health treatment, and a lot of times it's hard for our clients to pick apart the SUD and the mental health, and understanding that if you treat that mental health, the SUD could also be treated as well.
Yeah, if I could add to what Tricia said too, in being a certified peer recovery coach, I think what you said, Clarissa, about building that trust. I think just having that lived experience with SUD is when I do come across that with folks that I serve. I'm able to, I think it creates an environment where that rapport is more easily built. As we've had maybe some similar experiences, everyone is different. But I think that can kind of break down that wall and build that trust very rapidly. And so as an add-on service, I think invaluable to have that service for folks that do suffer from SUD.
Yeah, I agree with what you said, Trina. I think, basically having that experience and knowing what it takes to get sober. After 25 years of drinking, having 6 years of sobriety, and being able to explain to them, look, like, whatever you guys are doing, if it's drinking or smoking, it's not meshing well with your meds. And I've seen people who have had bad reactions and had the police called to their AFC because they are mixing mind-altering substances with those. So showing them something that they can resonate with, um, helps them understand better than somebody just telling them, look, you got this order. If you don't do this, you're going to jail or you're going to go to the hospital. So giving them a way, taking them through the steps, even taking somebody to AA, it goes a long way. I had another guy he's 60 years old. He never was clean. He had been doing crack and drinking for over 40 years. I made sure that I got him in a place. I filled out the paperwork for him. It was Town Missions, and he has been sober the longest he had ever been in his life, and it was just a joy to see.
Yeah, I agree. That's awesome. And I think what I found too was, being a peer and we had that lived experience, we also know about the like resources or things available like in the community to be able to say like, oh yeah, I went here, or here, here's what I did, and not necessarily have that effect of like, oh, I'm telling you, you need to do this because of the order, but like, again, coming from that place of lived experience, helping them get connected with resources, I think is great. Okay, going along, how does your role and responsibilities differ from an AOT case manager? And please describe your working relationship with the individual's case manager. Yeah, go ahead, Trina.
Yeah, I think that some of the things can look a little similar. I mean, I think some of them, helping someone get the paperwork, getting housing resources, et cetera, can look a little the same at times. I think how it differs is that the resources that we provide are a little different from the resources maybe a case manager would provide. I think that the boundaries of a peer's role are a little different than a case manager's boundaries. I think that we can kind of go out there and meet them where they're at a little bit differently than a case manager can, or is able to, depending on what agency they work for and what those boundaries are. I think I want to say lived experience, but I think there are some case managers out there that maybe do have lived experience as well. So I think sometimes that can be a difference. And I think it's always important to, coordinate care with everyone that's working with the individual. But yeah, I think the resources just look a little different, and we're able to kind of go beyond the scope that they're able to go sometimes.
Trisha, did you have something you wanted to add? It looked like you were going to
I did. Sorry, I was going to add. My role's a little bit differently just because I work with our clients from the time they get out of the hospital till they connect to that case manager. So I work for a very short time, just trying to make that connection. Hopefully it's a short time if we can get that connection made quickly, but it's again going out into the community and somebody a little bit more relatable for them to speak to and kind of get them to understand what's going on and what is, happening. A lot of times people feel like their rights are taken away. So if they can talk to somebody that has that lived experience, it can make it a little bit easier to get them connected to that case management.
Yeah, thank you. Could either or any of you speak to maybe, because I think the other part of the question was describing your relationship with the case manager. So like maybe what does the coordination look like between, I know you both kind of made comments about that, but I wonder, you know, kind of what the coordination might look like for someone who maybe is assigned a peer to the case manager.
I know for me, once they're assigned for a case manager, we just kind of support that case manager in any paperwork that they need done or questions they have about the court processes, helping with recertification appointments and things like that, if they have any questions, mostly with paperwork or ideas on how to re-engage if they've stopped engaging with that case manager.
Okay.
I can add a little bit if I can to that. I think, you know, I think peer roles they differ sometimes depending on where you're at. But if you're continuously working with someone, my coordination with a case manager has looked like keeping them, kind of up to date on things, being available for them to lean into me for questions or support as well. Kind of being on top of what the treatment plan looks like, what the plan looks like moving forward, and where those needs are that they're being able to identify with the individual, and not keeping it separate, like really being kind of a team, being team players about working with the individual and kind of treating the individual as a whole instead of one little piece and one little piece. I think that's, in my experience, that's been my coordination with case management.
Yeah, I would like to add, sometimes we see a goal that the case managers don't see. They might see them bi-weekly. By me having a particular group, I see them four times out of the month. And then I'm also seeing them bi-weekly. So that's 6 times that I'm seeing one. So I may see a goal that they're not reaching, one that they need to reach, and one that they reach. So I coordinate back and forth like that to help implement goals in the IPOS with the case managers.
Yeah. Yeah. And I know that I've definitely gotten questions from case managers of like, well, you know, what is a good way for, do you have any tips for how I can build rapport with this specific person? Or, you know, and then, you know, I found that sometimes I was able to, like, kind of like what you said, Jason, like draw out information about their goals that maybe the case manager didn't realize just because of that relationship and the amount of times you're seeing them. So, yeah, I definitely agree with that. And just as a reminder, I think there's some questions popping up in the chat, and there will be a Q&A after the panel questions are done, which we're on the last question. So we'll get your questions answered soon. The final question for the panel is, in cases where an AOT client is non-compliant and the case manager is unable to engage, what strategies would you deploy to try and engage the person? And please use real examples if you'd like.
That's something that I try to do quite a bit. So going out into the community, trying to locate folks. We do a lot of internet searches, working with the local hospitals and jails, trying to locate people as well. We do a lot of community outreach, and really trying to build that rapport once we can get a hold of them. I have found has really helped keep them engaged once we're able to make that initial rapport with them.
Yeah, I used to work when I was a peer, I was on the engagement team. So literally our job was to help engage people that we couldn't get in contact with, or that people were having trouble because they were missing appointments. And so I remember that being very much like mini detective, like, oh, this is where they might have come here. Let me go look there. So there were many times I showed up in a random parking lot looking for somebody. Yeah, so that was fun. Yeah,
Yeah.
Trina. Oh, sorry.
Sorry.
Go ahead, Trisha.
Go ahead.
I was
Trish.
just gonna say, like, we have made up like goodie bags to bring to our clients with stuff that they might need in the community, with also some mental health resources in there as well. Um, snacks, food, you know, things just to try and help them feel a little bit more like we are there for them and trying to help.
Yeah, yeah. Trina, you had something to add?
Yeah, I just real quick, I think another tactic also is in engaging like community partners that may already have a relationship built with the consumer if you haven't already had an opportunity to build that rapport, or they're new, or I think that can be an important aspect too.
Yep, that's a good point. Okay, well, that concludes the panel questions. Any other final comments from our panelists about those questions or anything else before we move into the Q&A portion?
I actually do have to head out. I was only going to be able to be here from 11 to 11:30. So thank you for the opportunity. And it was nice to be on here and meet all of you. So thank you again.
Yep,
Thank you, Trina.
Bye.
For your time.
Okay, so I suppose we can move on to the Q&A. Olivia, how do you want me to do this? Do you want me to,
I
say the
can,
question, or do you want to
no,
do?
that, yeah, no, that's all right, Clarissa. I would love to, go over, some of the questions we've gotten in the chat, and like if anybody else wants to just raise their hand and talk as well, and then, I can facilitate that. And again, if you have a lot of valuable experience, if, you can answer these questions also, so I, so
I
one of the, oh, go
Real
ahead.
quick, sorry, because the first question that I got was a direct message, so I wanted to get to that one first because he
Oh,
had been waiting.
go ahead.
Was from Daniel. He asked, "What are the best ways to incorporate a peer for the first time into an AOT team?" So I just want to make sure that got out there because it was a private message.
I'm sorry, Clarissa, would you mind repeating that one more time?
Yeah, it was, what are the best ways to incorporate a peer for the first time into an AOT team? So that was a question that Daniel posed.
I know with our agency, we really try to have a peer do the transportation, if they're coming out of the hospital on an AOT, to make that warm connection right from the beginning. We're the ones picking them up and can have that short conversation when we're coming back for their assessment, just to give them a face to, face and a name, and kind of explain that this is a scary situation. You're not in trouble. It helps a little bit, when they're when we can see them immediately while they're still doing well.
That's lovely. I see that Christy also had her hand up.
Yes, I just wanted to add to what Trisha said. We actually start our connection with our consumers that are on AOT at the deferral conference. And at Trisha, being our court peer, she sits in on all of those deferral conferences. So she's starting from the very beginning of their hospitalization and then walks them through this process until they have a solid connection to the case manager, because sometimes they'll show up once and not come back. If they're not coming back, we're back involved. So that's how we engage up here, is right from the beginning, as soon as they're admitted to the hospital on an involuntary status.
Thank you. And Sophie, I see that you had your hand up.
Yeah, first, can you hear me?
Yes.
Thank you. Chrissy's point just kind of brought up a question I already had written down. So I've heard a lot about the barrier that insurance or Medicaid can play, and maybe like what
Sophie, I don't mean to cut you off, but your mic is kind of breaking up.
Okay, I'll put it in the chat.
Okay. Thank you so much, Sophie. I did have like a question for myself that came up during, and it's kind of related to this. I mean, it is related. So is it a practice that anybody has in any of their counties where um, they have peers accompany law enforcement when they do transport orders or pickup orders? Is that something that anybody does? Trissa, I see you shaking your head, yes.
We do from time to time.
Okay.
Depending on the social worker and the client, they will
Mhm.
ask us to come on out with them.
Gotcha. That's wonderful to hear. Does anybody else have that experience where they have peers accompanying law enforcement?
I'm sorry. I also just wanted to say we have a great relationship with our police department and our social workers at our police department that makes that connection very easy. We work together very well with our social workers of our clients.
Amazing.
I was just going to say that I can't say that that does happen, but I just think that's a great idea. So thanks for putting that out there.
Yeah. Wonderful. Okay. Oh, Jason, go ahead.
Yeah, so the law enforcement definitely helps out dealing with some of the AOT, the case managers and the participants who win it. I had to do a panel for them, and we had just recently had an instance where one of our people had stolen a car and had went out of town. Now the law enforcement knew who they were just because they had a case manager. So having that connection, sometimes they don't know when people are offered their meds or if somebody is just, as they say, tweaking, so having that connection, the police understanding, taking mental illness serious, and calling the case manager helps get that consumer back to where they need to be, back on their meds, and violating the AOT order. I had to work directly with the guy while he was in the hospital. Had to spend some time in there, but at least he wasn't in jail because the police understood that hey, this guy is off his meds. Let's get him where he needs to go. So having that connection with the case manager, the peer, and the law enforcement keeps everything in perspective.
Wonderful. That was a great answer. Thank you. Okay, so yeah, there have been various questions in the chat that I wanted to make sure that I captured. So Sarah asked, is everyone on an AOT assigned a peer support at your agency? And I know that I believe that Trisha
I changed
said,
my answer.
oh, okay.
Because we were assigned right at the beginning, I had misunderstood the question.
Mhm.
I wasn't sure if once they get to the case management, if they're all assigned peers, just because I'm not a part of that process. So I apologize for my misinformation.
No worries, no worries at all. And this could differ from, from county to county. So can anybody else, even if you're not, a peer, or if you are a peer, is everyone on an AOT assigned to a peer support at your agency?
So with D-Win, they're not necessarily automatically assigned. And D-Win is the PIHP. We actually do have like our ALT grant now that allowed us to hire 2 new peers, but we are struggling with getting people to be interested in our peers. We're really like trying because we can see the benefit, even if it's just a matter of them getting the person to that first intake appointment where they are with one of our outpatient providers, but we're not getting a ton of buy-in from the hospitals or even the CRISP when like, because the CRISP may not necessarily have a peer. And so we're like, okay, we can, we have 2, they're waiting, they're ready. and we are struggling with the buy-in. But we're going to keep trying because we absolutely know that there is a real benefit there for our members. Like I literally saw 2 today during deferral conferences where I was like, I'm just going to connect you with the peer, and whether or not you ever want to talk to them again, that's fine, but we're going to connect you and just see what happens.
That's great. I think that's a really, really great segue to Haley's question in the chat, which she asked, prior to meeting with the peer support staff, what is the best way for providers to describe the role or goals of peer supports to consumers, especially to those consumers who have never worked with the peer support before and might be a little skeptical or less trusting of others? I think peer supports are a great resource, but I find that consumers sometimes struggle with differentiating peers from other mental health treatment providers. So I think that's a great segue. You know, how can we distinguish the value and like, you know, everything that we've been talking about here today, like how can we convey that to an individual and the value to an individual to where they understand and can differentiate between between a peer and another mental health professional. Did anybody have any thoughts on that?
Haley, I think that's a great question. Something that's hard for even peers to answer. But I think by letting people know that peers are somebody who have been through the same kind of treatment. We've been in a hospitalization or some kind of treatment that we've needed. And there is hope. These people are now working full-time jobs. They are, you know, we've come a long way from where we were because we've accepted our illnesses and decided to get that treatment. As well as another thing I'd like to say is peers are not friends. I hear some hospitals will say, well, a peer will be your friend. We're not. We're here to support you and we're here to help you. But sometimes when they hear the friend, then a client automatically, that can be a whole nother problem in itself. But to know that these are people that have been in a hospitalization, but they have a house, they have a car, they have a job, they're doing all of these things. So there is hope that I could be doing those same things in the future as well.
Yeah.
I'd like to say, this is Charles. I've been a counselor and I've been in the mental health for about going on about 30 years. Probably time for me to retire, but you know, I in the last 4 years, I joined with Live Right. I never have, it's the grant, I never have worked with peer support. I just always work with the mental health. And it's just been so amazing. Live Right, having a peer support, just never seen anything like working with peer support, because I heard someone talk about the connection that the counselors and the case managers that we have that sometimes we miss, and I have missed, and the peer coaches have brought to my attention. And so I just think it's just amazing program. I have really came to the sense of appreciating every peer support. It's just amazing what they do. And you know, the stories that they have, where they come from and their lives and where they are now and how they really have connected with the mental health. So I just think so. I just take my hat off to the peer program and the peer support. Really appreciate you guys working with us as counselors and case managers and being out there and, you know, kind of letting us know what we miss. Sometimes we behind the desk and we really don't see it. So thank you so much.
Thank you so much. And I echo that 100%. I see that Tracy, you have your hand up.
I do. Good morning, everyone. My question is, and I know Clarissa and I have talked about it, Clarissa actually mentioned it. so in terms of how you're messaging, to be under a court order could be perceived, and of course I'm getting a phone call. The court order could be perceived as a punishment. A lot of people, of course, if they're, sick, may not be able to process the nuance of that, right? Like you're not in trouble, but you are under court jurisdiction. So I guess the long story short, how do you all message that in a way that it doesn't come across as punitive, but more, therapeutic and supportive? Like, what do you do to make sure that message comes across in that way?
I'd say for us, it's building that rapport and, talking to them about making sure they understand, explain, making sure they have my phone number if they have questions. A lot of stuff is happening when they're coming out of the hospital and on those orders that they might not understand what is happening at all. So building that rapport so that, and I stay very honest with my people about this is what could happen if you don't comply. And I find a lot of them respect that and will, it helps me build that rapport when I let them know. And I'm not going to tell you just the positives. I'm going to tell you anything that can happen. And then, it's going to be your choice on how you want to, go from there, and kind of giving them that independence of this is what the judge says. But if, you don't want to follow, I do want to be honest and let you know, this is, what is going to happen. I really try to lay it out so that they can understand these are all of your options and these are your options to choose. And these are the pros and cons to each of those.
That's lovely. Thank you so much, Trisha. Jason, did you have any thoughts on that, on building that rapport with individuals, especially those who might just the mere, being on a court order could be seen as very punitive. And I know we talked about earlier how it can be like a really hard thing to reinforce. It's like, this is not criminal. This is, you're not necessarily in trouble, but can you talk to, how you make that distinction with people you work with?
Yes, I get this all the time with a couple of my AOT participants, and over half of my domestic violence consumers. So building that rapport and letting them know when they tell me I have to do this for the court, I'm ordered to do this. If I don't do this, then this will happen. And like Trish was saying, explaining to them about those pros and cons. And at the same time, we actually did a lesson on this. So what part of this is in your control? Where the courts are controlling this. I said, but is it keeping you out of the hospital? Is it keeping you out of jail? And they say, well, yeah. I said, well, the courts aren't really controlling your life. This is where I give them the control. Because I said, what percentage of this can you control? What is in your control? Can you control the outcome of it? And they think, oh, well, yeah, I can control the outcome. So this makes them more apt to keep coming back. So that's what works for me.
Thank you so, so much. Clarissa, I see that you have your hand up.
Yeah, kind of with both questions. So speaking when I was working as a peer, which can look different with what I do now, but when I would have, I guess the way that I would frame it was like, I'm a person, I have lived experience, so I may be able to relate to some of the things that you're going through or that you had, gone through. I've received services, I'm at a point where like I'm in recovery, working on, whatever. So that's kind of how I'll frame it. So like, it's like, yeah, I'm in a role of supporting you, but also like making them feel like we're equals, because sometimes there can be this power dynamic between like a psychiatrist and the person, or even a case manager, regardless of those people might have their own lived experience, right? But as a peer, you get to share that lived experience, which is not always like you can't, that's like a boundary that's not really crossed in other roles. So yeah, taking away that power dynamic. And then speaking to what Jason said in relation to Tracy's question, is like empowering them and still keeping like, yeah, that this, it meant being real with them. Like, yeah, I hear you. Like, wow, this court order, yeah, it's, I know that this is overwhelming, and validating them in that, yeah, this is probably really hard for you, but trying to give them back that empowerment, trying to give back that power that like they do have control over some of the things and in their care. And I really tried to work with whoever, like if they had a case manager, like bring it back to that person-centered care, right? Like we have to do what's in the order, but also like this person has things that are important to them. Let's think about that. How can we incorporate more of that into their treatment so that it's enjoyable for them? Because if they're just doing whatever they need to do because it's on the order, they're not really participating fully in their services. But if we can do something that's important to them, that they enjoy, that they would love to work on, that motivates them. So yeah, that's my response to that.
Wonderful. Thank you so much for all of your perspectives. This is great. There was another question in the chat from Sophie that I think is that I'm personally really interested to hear the answer to. So can anybody speak to the barrier that insurance or Medicaid plays in what peers are able to do?
Fortunately, I cannot, because that's not something that I see very often. I apologize.
No,
Yeah,
that's all right.
For D1's peer, since we're not directly billing, we're not so much concerned about like what is billable and what is not. I know if I had to assume from all my years as a case manager, I would bet like that whole driving around to find them and spending all that time where you can't bill, but you know the person may need you to do A, B, and C is probably a barrier, but it's just not one that we have because we're not billing for our peers.
Gotcha.
I could add to that real quick, just for like I work more particularly with the senior community. I would say that one's a difficult one. I'd say especially so with getting somebody placement. You know, that whole obstacle with the Medicaid or Medicare, you know, and how they assess that. Sometimes that can take several months, which is not super timely for you try to set up somebody getting proper placement. So.
Copy that.
I know at our agency, again, when I was working as a peer, and I don't really know what the status of it yet, but as far as I know, they're still not doing billable services. There's different types of peers at LifeWays itself. There's like crisis peers, the engagement peers. There's a couple other peers that work, and I don't think that any of them are providing a billable service. But then we do have umbrella service, that's they run a drop-in center, and some of those people are like assigned to cases, and I think they do bill the services there. As far as I know, I think Medicaid, like most of those people do have Medicaid, and I can't really speak to like how many or who of them or what the requirements are in terms, like if you have private insurance. But I do know that we have a drop-in center, so like people can somewhat access like some peer support, not necessarily in a formal service, but they can access it through that drop-in center. So I think in order to qualify there, they have to have been in our system and have a diagnosis of a mental illness, and they have to bring some kind of proof of that. But yeah.
Gotcha. Excuse me. I see that in the chat. I see Sophie says that I assume that there are certain parts of the treatment process that peers aren't involved in because of those restrictions. So, speaking from a peer's perspective, is there anything that you wish you could be more involved in, or an area that you see potential for peers to be more involved in?
Yes, if I could chime in on that, I would like peers to be more involved in creating the IPOS goals and even our own authorizations. I think would be a good thing. It'll take less stress off the case managers, um, and at the same time, we wouldn't have to keep, reaching out when we need more authorizations or when we have a different goal. Long as we coordinate with that each other, I think that would be good.
That's a great suggestion. I see that Trisha, you went off mute too. Did you want to add to that?
Just a little bit. I agree with him as well. I have just noticed at my previous location they used peers a little bit differently, and they may use them the same here. In my role, I don't see how case management and everybody uses their peers. But I've been kind of like everybody else, where peers sometimes only have a peer. They don't have a case manager, but they're still meeting with them weekly or twice a month. And it's still being very helpful in taking that little bit of that load off of the case managers themselves. And you still have the case managers as a backup, to speak to if you need to. But I have seen that helpful in other places that I don't, and I'm not saying it's not happening here. I just don't see it in the role that I'm in now.
Gotcha. All right, so we're at 11:55. I wanted to just open the floor and ask, does anybody have any just like last minute thoughts or ideas or praise? I mean, like this was an amazing panel. Thank you so much, Jason, Trisha, and Trina for coming, and Clarissa for facilitating. Like this was such an amazing discussion. Like thank you so much, truly. And yeah, so I just wanted to ask if there was any final thoughts.
Olivia, I'm not sure if you answered this, but Jenny did pose a question in the chat.
Yes, I did see that. It was yeah, a lot of questions. Like very, very many questions. So, with us not having that much time left,
It's okay to skip my questions.
yeah, yeah. Thank you, Jenny. Um, so yeah, so again, thank you all so much. I just wanted to plug again the court variance survey before we leave here. I'm dropping it in the chat. Again, if you can share that, if you can do it yourself or share that with other folks who you work with on AOTs, that would be extremely helpful for us, as we want to know how court processes are differing across the state. So thank you again. And yeah, again, thank you to our amazing panelists and facilitators. I hope everybody has a great weekend and take care.
Thanks, guys. Have a good weekend.
Thank you.
Thanks, Trisha.
You.
Thank you, peers. Thank you so much.